The survival benefit's obvious. So if you looked at any of the trials for the HeartMate 2 or the HVAD from Heartware, they both show significant survival benefit over medical therapy for patients who are in end-stage disease. So you really don't want to put the VAD in just any heart failure patient. You want to wait till somebody has fairly advanced symptoms, pretty high morbidity. These are usually patients who have been in the hospital a few times, who have exhausted all their medical therapy, their blood pressure's dropping, you're peeling off their beta blocker, peeling off their ACE inhibitor because they're starting to get lower blood pressure. They can't do things that they used to be able to do, like even get dressed or take a shower. And so those are patients where I'm really thinking, okay, there's some quality of life issues here. Now, if the patient's already listed for a heart transplant and the feeling is they're going to die waiting for a heart transplant, often the decision will be to put the VAD in so that they can be listed for heart transplant and live long enough for a donor to become available. But for certain patients that may not qualify for heart transplant or may not want a heart transplant, the ventricular assist device then becomes destination therapy. And the 1-year survival can be as high as 80-90% at certain centers. And with medical therapy, the 1-year survival for the same patients would be 20-30%. So we're looking at a big survival improvement for the ventricular assist devices. Typically patients who were, again, ICU bound, bedridden, or couldn't walk across their living room without getting short of breath are now walking farther. They're much more independent. So the quality of life improvement can be very dramatic. Trade-off is they're carrying around 7 pounds of equipment with them. It's always attached to them. They have to remember to change the batteries, and they have to take anticoagulants, which they don't always, people don't like to take Coumadin. So it is something we have to talk about. And there's readmissions. They don't necessarily come back in for heart failure, but they come back in for bleeding or concern for infections. And so they don't necessarily get to be hospital free, but they're not short of breath all the time, and they're not limited. And a lot of patients leave the hospital after their VAD and they don't have to come back. But there's no cure. It's not the cure. It's another tool that we can use. And for the right patients, if you do your selection well, the quality of life and survival improvement can be very significant. They started off as being available at transplant centers. So anywhere you can think of that will do heart transplant does ventricular assist device. And the original devices were very big, they were very clunky, they would break down. Patients would get them and not necessarily be discharged from the hospital. As the continuous flow devices became available, the reliability increased and patients were actually able to leave. And I wouldn't say that taking care of a VAD patient is a cakewalk, but it became a lot easier than it used to be. And hospitals and centers that didn't take care of transplant patients became interested in having the technology. I still think that the VAD surgery has to take place in a tertiary care center that has all the specialties available to it, but many centers such as UC Davis do not have heart transplant programs but are implanting ventricular assist devices. In Sacramento we have 3 programs, but only 1 heart transplant program. Smaller community hospitals may not feel comfortable providing this therapy now because of the ongoing follow-up it takes and complications can arise. But there are shared care models where the implant and initial care will be done at a larger tertiary care center. Patients can go back to the referring cardiologist and get care locally, for example, for Coumadin management, or if they needed minor treatment, at their hospital locally, they could still do that. We're not close to any of these therapies, as far as I know, in terms of coming to market, but I think the biologics, gene therapy, there's all sorts of bench work going on, building scaffolding of tissues, artificial organs that are cellular based, not mechanically based, I think are definitely interesting to talk about. Stem cells have been around for quite a while. We've been infusing stem cells through the bloodstream locally. There hasn't really been a stem cell study that's made anybody in the heart failure community, really adopt that therapy for their patients. But certainly, there's a lot of interest. There's a lot of funding associated with that, and so that is an area where people are interested. But I always tell my patients, if you're holding out for stem cells, don't. You should really be thinking about what's approved right now, and the clinical trials that are ongoing are really for the next generation pumps and things like that. So we're still in a very mechanical age. But again, that's 5% of the population. The other area of development is home-based care. And so there's this other 95% of the population that is not necessarily having advanced heart failure, but they're symptomatic. And these are patients who are, for the most part, getting by on their diuretics, their medical therapy, and there's a huge amount of interest in home monitoring and it's another kind of tech where it's not doing things to the patients, but it's enabling patients to better do better self-care by having them do their own blood pressures, having them check their weights. There's invasive devices that you can actually implant in the pulmonary artery that will tell you what the pulmonary artery pressure is on demand for a patient at home. We have several patients at home on the device, the CardioMEMS device, where we can actually look up what their pulmonary pressures are and dose their diuretics based on that rather than using the weight. There's this whole other arena for the non-advanced heart failure patients who really can who need a lot of self-care, need a lot of monitoring, and we're trying to build a better mousetrap other than just weigh yourself every day, call me to take extra Lasix or whatever. And so that's going to be an interesting area too. And a lot of the existing device companies that are already making pacemakers and defibrillators are definitely thinking about how to use those existing devices or other similar technology like this Fitbit, to say, oh, my patient was walking 10,000 steps every day this week. But now today they're only doing 2,000. I should call them. Maybe they don't feel good, And so I think using algorithms like that to determine which patients we should be calling rather than telemonitoring everybody every day, which is a lot of nurse time, really being smart about it. So that's an interesting area of development that I don't think we talk about a whole lot because the machines are much, more glamorous, but really the portion of the heart failure population that would benefit from them is very small, and there's this huge other side of the population that needs help, and that's definitely an area that could be very closely managed with primary care, general cardiology, and nursing.